Assalamualaikum warahmatullahi wabarakatuh. My name is Amir Khan Busra, and today I would like to present a case study that I encountered during my practicum in the trauma and emergency care setting in the hospital Taipei. Uh, the focus of this case is patient who present with an episode atrial wall elevation in the myocardial infarction or STEMI by the I will guide you through the program, the definition of myocardial infarction, the detail of the patient case, and the stabilization performed, the treatment plan, and expected actual outcome, and finally a discussion, lesson learned about my conclusion. My goal is want to uh, how early recognition, appropriate intervention, and the effective treatment and can significantly improve the prognosis in acute cardiac emergencies. So let's go to the introduction of the myocardial infarction or MI occurs when there is a damage to the heart muscle due to the prolonged interruption of the blood supply. The most common cause complete blockage of the coronary arteries, which usually happens when arterial plaque ruptures. This rupture can be triggered as a cascade. The platelet aggregate, thrombus form, and the blood flow to the heart muscle stop without oxygen. Myocardial cell begin to die. By the specific case, I would like to show you how the pathophysiology in the myocardial infarction. It begins by the plaque rupture in the proximal left atrial descending or LAD. This was followed by the thrombus formation, causing a complete coronary occlusion. Can be the patient to develop crushing, chest pain radiating to the back and left shoulder, and the shortness of breath, and patient will be the paralysis by without the primary prevention, irreversible necrosis of heart muscles cell will be occur. For the symptom of the myocardial infarction, you can see by the chest pain, sweating, nausea, vomiting, and breathlessness. However, in the elderly age woman and diabetic patient will be more fatigue, unexplained breathlessness, or dizziness without the chest pain. So by the diagnostic tools, we can see, how about we need to have a ECG to know about the uh, condition of the myocardial infarction. You can ask the patient about the history by the physical examination. But the most important is by the serology. If the blood specimen is totally high quality, you can know how the severity of the uh, myocardial was damaged. By the treatment agency, you can know within the 90 minutes of the first medical contact, you can need to have a PCI, whether PCI is a percutaneous coronary intervention is a more effective when a patient have a medical infarction. But in the some place in the rural, but if PCI is not available, but we have the fibrinolytic therapy, that's like certified can be more the main profession of to give to the patient by the intravenous. And this case report not only the describe the clinical journey of the patient, but also underline the importance of quick decision making and the role of the secondary prevention and cardiac rehabilitation after the acute phase. So by the case detail of the patient Mr. A, 63 years old, male Malay, by the occupation is a farmer, and the address is the Kampung Bendang Nerin, Batu Kurau. So patient present by the chest pain at the onset, pain relating to the back and the left shoulder, shortness of breath, and the patient started to vomiting. And the history patient had never had a medical checkup, and the patient known case of the uh, hypertension, diabetic, or IHD, or dyslipidemia. In the patient by the lifestyle of patient, in a day, patient was a heavy smoker. Uh, he smoked a cigarette with two box of cigarettes. By the family history, patient had no when we explore the family history, we can know patient have a hypertension. By the family is hypertension and diabetes. The patient don't have ischemic heart disease or myocardial infarction. But this program still put him at risk due to the strong presence of the metabolic risk or the factor in the family. So by the physical examination, when the patient came to klinik kesihatan Batu Kurau, patient started catching his chest and discomfort. Patient come with a priority. And the vital sign patient is 155 over 90. The pulse is 86 beats per minute. By the spirit, the more increase is 54 per minute. By the SpO2, 96% of the patient is still normal in 57, but the pain score they very in pain is 80 and 8 per over the 10. By the finding of the head to toe basic examination that the patient have a jaundice, no pressure, cyanosis, the neck come to jugular-venous distension and as well as abnormalities and the typhoid is normal. And by the chest, cardiovascular and respiratory heart sound is still okay. Uh, the heart sound, the rhythm normal, and the lung sound is clear, no wrong time, no cracks, no have any abnormalities, and of the especially in the skin and then the patient don't have a no multiple redness or swelling. In the abdomen, patient is soft and turbulent, generally no bladder extension. The extremities capability are more than about 2 seconds. The patient in the good circulation and the fit low swelling of the kidney. So we move to the laboratory investigation. We need to know how the blood specimen we have taken to the patient is a full blood count, range of profile, liver function test, and troponin I, also the ABC. So full blood count liver and normal hemoglobin and hematocrit values, but there was a mild elevation in the white cell. Maybe the patient have an inflammation or stress response. The platelet we did a normal range. Random people they were completely normal and no immediate kidney involvement and liver function test were normal for terrible, but the liver was elevated. This might point to the mild liver or biliary tract involvement. So the results is totally either more increase 23,000 to 155.3 nanogram per liter for the above the normal range. By the confirm the statistic of the myocardial injury, and we know how the severity of the damage in the myocardium. In the EDG, antiplatelets have been analyzed show patient have got a myocardial hypoxia because they have 7.31. But this indicates infectious exchange which can be seen in acute cardiac events where the pulmonary condition of ventilation perfusion occurs. In the ECG, we show just I said to you about diagnostic tools. We need to know how the diagnosis of myocardial infarction is the rapid ECG. We show the standard. This is a result of the patient when he came to the clinic to Sultan Batu Kurau. Also, same the emergency trauma in the hospital setting. They show the accelerated heart rate between 70 and 80 beats per minute and the normal exist. But there was marked the ST elevation elite V1 to V6 as well as the 1 and regular, which suggests a trilateral myocardial infarction due to proximal AED attenuation. By the addition, there was a reciprocal antidepressant in the leads 2, 3, and AVM. The patient was consistent with acute arterial wall staining and together with the clinical presentation and rebate accompanying the diagnosis was confirmed that patient got myocardial infarction. In the for the treatment plan, as we can know, in the clinic Kesihatan Batu Kurau, patient is started with the GPN when the detect of the ST elevation in the 12 ACG, and they are given oxygen 3 liters per minute by the nasopron. Even though that the patient in the 96 SpO2, but we give oxygen therapy for uh, which patient complete the half of the shutdown of breath. In the local arrival at hospital take MRI confirmed with another ECG. The patient was given aspirin 300 milligram and clopidogrel 300 milligram as a step dose for dual antiplatelet therapy. Murphy was admitted to relieve his chest pain and he was placed under continuous cardiac monitoring. And the thrombolysis was initiated with intravenous tetanus over the course of 1 hour. But the sun were monitored 50 minutes to detect any adverse reaction. But during the infusion, the patient developed the hypotension, was treated properly with no adrenaline. Once blood pressure stabilized, the infusion was resumed. We have to stabilize the vital sign of the blood pressure, and then when the hemodynamic was stable, we continue with the thrombolysis therapy is a certain within the 1 hour infusion. After the post-thrombolysis, which was monitoring for cardiogenic shock, whether it can be classified as clinic plus 4, he was then referred to cardiology team for consideration of PCI, and firstly, we need to admit the patient in the CCU for ongoing management. So the next expected treatment, we expect the treatment restoration of blood flow to the ischemic myocardium, which will reduce the extent of muscle damage within 30 to 90 minutes after thrombolysis. We expected to see relief of chest pain and a reduction of ST segment libration. In the combination of aspirin and clopidogrel and also steroids can be aimed to reduce the risk of the complication, can be prevent further clot formation, and improve overall the cardiac function by lowering the risk of uh, mortality. For the actual outcome after we give the treatment from the treatment plan, uh, patient hemodynamic status to improve after the low adrenaline infusion in the oxygen saturation still and more to increase to 97%. Um, then the blood pressure is stable. Then the streptokinase infusion produces a positive therapeutic response. Antihistamine elevation decreased by less than 50% compared to the baseline of ACG. Which indicate clinical improvement. The jugular venous pressure also reduced, showing a better cardiac pressure and improved coronary perfusion. Overall, despite the brief or episode of hypertension and cardiogenic shock during the thrombolysis, early intervention were stabilized the patient and his was prognosis will be more positive. So let's go to the section 4. How does this we want to discuss about the case with case my case is a microdepression, how the management uh, for the microdepression in clinic kesihatan to the hospital pattern in the emergency and trauma unit. So we know the patient will present with a classic MSC crushing, pain over radiating to the shoulder and back, and SUB. We can saw on the ECG and ST elevation. Everyone to disease. We know that have changes reciprocal ST depression 2, 3, and ABF. We know that troponin I more increased to 53,255 milligram. For we want to focus in the primary survey, secondary survey, and emergency intervention. We know from the moment a patient arrives, we can apply the ABCDE. These are Airway circulation, disability, and allergy exposure can be approached aggressively to rule out life-threatening issues and ensure the stability. And the circulation allow us to collect the complete history and perform a detailed examination. In the emergency detection, we can follow by the MONA. MONA is a morphine, oxygen, nitrates, and X-ray. Along with the COVID as a dual articulated therapy, the strategy was used as a reprovision method, which is essential in rural settings without the immediate PCI access. So by the early detection of STEMI, we can use ECG and biomarkers is just like troponin I, but we know how the golden hour in the myocardial infarction is more important. We can continues to monitor to detect and manage complication. This could also highlight the role of the teamwork from the rural clinic to the emergency treatment to cardiology and ensure give a more decrease know how to demonstrate how even the rural healthcare setting without the PCI facilities effective use triple can be saved the patient and patient know to go to a more complication and we want to uh, reduce of the mortalities. But the collaboration between the clinic and emergency unit and cardiology can be potentially save timely, appropriate care. For me personally, this really improve my confidence and enhance my clinical skill, reinforce the importance of the prepared, close observation, and empathy in the patient care. So, can conclude my presentation. Thank you for your attention, and I'm happy to give you during my practical in the hospital setting for my subject trauma and emergency care. Okay, Assalamualaikum.